If you'll take your seats, we'll get started. It is with great pleasure that we introduce our distinguished speaker, Dr. Mandi Pratt-Chapman, an associate professor of medicine for the GW School of Medicine and Health Sciences, as well as an associate professor of prevention and community health for the GW Milken Institute School of Public Health. Additionally, she serves as the Associate Center Director for Community Outreach, Engagement, and Equity at the GW Cancer Center.
Thank you so much. And I'm so glad to be here with you all today. I know thanks. Seriously, you can call me Mandi. The academic centers like give you all of these titles, right? Like, because you have to fit into all these buckets. So it's always kind of embarrassing, I feel like, when I'm introduced. But you can just call me Mandi. I'm going to be talking about queer health in general in terms of cancer, and then specifically if we want to talk about cervical cancer, we can do that too. So I always like to kind of say what I'm going to say before I say it so that you know what's coming. So I'm going to be talking about lived experiences of queer individuals, and this is actually a very good follow-on to the discussion that was just had about stigma. And then I'm also going to talk a little bit about some unique considerations across the cancer continuum and some of the research I've done in this space, and then also provide some resources. So I think this will be not unfamiliar to you at this point, given the other conversations that have happened today. But I often speak with providers, and I have a sense that we have more survivors than providers in the room. So kind of take what I'm saying in the context of how to, kind of empower yourself and support each other. But when I'm talking to providers, I often invite them to think about intersectionality and where we all have power and where we maybe are more vulnerable, so that kind of reflection can help us be more inclusive and more compassionate in terms of the power dynamic that naturally happens in the room. And so I think especially right now, I've talked to a few people today as I've been in the back, I think we're living in this very polarized world right now. And like the more that we can kind of be compassionate and reflect on each other and where we might experience moments of vulnerability and how to lift each other up can help us do better work in the health system and in our society. So LGBT people, just like lots of other people who experience stigma, and all individuals are really kind of affected by social determinants of health, right? But we are inordinately negatively affected, just as other individuals who are stigmatized are inordinately affected by social determinants of health in terms of poor health outcomes. So what does this mean? This means that how much money you make, what job you have, where you live, whether you have family support, whether you have a safe place to exercise and eat, and whether you have access to a healthcare system, what kind of insurance you have, how people treat you when you're in the healthcare system, how far away it is, all of these things contribute to our health outcomes. And so when we're talking about disparities and we're talking about inequities, there's nothing essentialist about it, right? Like there's no, it's not because you're Black or not because you're queer or not because you're poor that you have a health disparity. It's because the system is set up to not, there's not like a natural, it's associative, right? Because these things are going against us. It's not like causal, right? So you don't have worse health outcomes because you're queer. You have worse health outcomes because of transphobia and homophobia and laws that are increasingly being passed in this country that alienate us and make us unwelcome and take away our rights. So when we're talking about minority stress, there's a number of levels that we're affected kind of by minority stress. And I realize too that I'm preaching to the choir here. So take what's helpful and leave what's not. But we have kind of interpersonal, or we have internal homophobia. We have internalized not discrimination, but prejudice within us. For example, when I came out at 32, I would say for probably 2 years, I thought of myself as a straight woman who liked women because I was so socialized to think of myself as a straight woman. And I was raised in a fundamentally evangelical environment in a rural town that was very homogenous. And so just getting my head around how I talk about myself or how to describe myself was very challenging because I had just learned to associate certain words with myself, even though it wasn't me. And then we also sometimes have worse social support, or our social support systems look different because of historically family rejection or lack of traditional family support. So sometimes our support systems in the health system look a little bit different. Sometimes that changes depending on geographically, right? We're in New York and there's a lot of protections here. Depending on where we live and work, that might look very different. But for me in rural Maine, I didn't know anyone out when I was a teen. My family was challenged, to say the least, when I did come out, although we are still close. So, just keeping these things in mind that we're not all at the same we don't experience the same privileges and the same assets that society kind of assumes for kind of this mythical white cisgender tall financially stable man, right? Like that's kind of like what everything's compared against in terms of how our country's built. And this is something I've been thinking about for like the last year or so. I was like, why is it that we associate stress with poor health? And I'm like, okay, stress doesn't cause cancer, but we have these aberrant cells that are circulating all the time. And I can't remember who was speaking earlier today, but they were talking about a child appropriate way of explaining what cancer was. And I thought that it was really clear and brilliant. And this idea that we have cells that are circulating in our bodies all the time, and the ones that are kind of evolved in ways that are not normal are supposed to die, right? And if you have cancer, they might proliferate, or your cells might be, you're creating an environment where there's this laboratory where the cells can become more aberrant and therefore lead to cancer. So it's not that stress causes cancer, it creates the conditions, a kind of a petri dish under which cells can proliferate and then become cancer. So I hope that that's helpful because I needed to do some thinking about that as a scientist. So I'm going to move to the kind of what do we miss in clinical care for LGBT people. So we miss collecting information about sexual orientation and gender identity. I say we generally as a health system, right? That's a broad generality. Some people do ask about sexual orientation, and actually New York is leading in that area. But we need to know what to ask. We need to know how to ask it. We need to know where to store it. We need to know how to use it. And we need clinicians that are both culturally and clinically competent. And then we need affirming care context. So we need to be seen. And, a study I read recently, I thought really resonated with me was there was a recent study conducted of LGBTQI people and what did they want to see in health systems in terms of visual cues. And the results were that we want to see everyone. We want to see people that look like us and people that don't look like us. We want to see everyone. And so I always encourage healthcare providers, like, have your images, your brochures, your posters reflect the patients that are coming in the door and that you want to welcome, including us queers. So this is some of the work that I've done in the last couple of years. So I was lead author on this paper, All Research is LGBTQI Research. And the idea behind this paper was really just that we can't just collect sexual orientation and gender identity data for queer studies, right? Like we need to be collecting sexual orientation and gender identity data so that we can look at all of our scientific research and learn how to provide more appropriate clinical care to queer populations. And without doing that, we're going to have to replicate many, many studies, and our sample size is going to always suffer, right? So, and we also are really bad at guessing who's gay or who's queer or who's trans, right? Like it's not like we're wearing a sign. So not asking about these things is actually leading to erroneous science because we're assuming things that are incorrect about people, and we're not using the information that we need in order to better guide improved clinical care. So we also don't know how to ask about sexual orientation and gender identity. So this report from the National Academies came out, and it was really frustrating for me, but it was a start. But they were tasked with distilling what is currently known about sexual orientation and gender identity in the research literature. But unfortunately, the way that we've asked questions sometimes lack face validity. And I don't know if that's because straight cisgender people are doing research on queer people, or I don't know what that's about. But basically, they summarized research that in and of itself was kind of a shaky foundation in terms of how we were asking some of these questions. So it's a start. And I've been working with a team of 6 colleagues across the country to refine the way that we're asking questions. So for example, in this report, they have a question, are you male, female, or transgender? Choose one, which doesn't make any sense because you have to choose at least 2, and it's also a gender question that has sex constructs. So it's very confusing. So we're trying to improve how we're asking these questions, and we have a forthcoming paper in JOP that will be providing our new recommendations, and then we're also going to be cognitively testing those items with a variety of people. And if you're interested in maybe signing up for that, we're going to be doing interviews in the next month, and we want to have maximally diverse participants, including straight people, queer people, white people, Black people, Latina, everyone, so that we have a good idea of if these questions are actually working for people at large. This is a study that I published about a year ago. A friend of mine asked me to write a paper on gender in a radiation journal. And I said, okay, because I was supposed to get a PhD in English. So I've done a lot of writing. Like I have a bachelor's in English, a master's in English, and almost a PhD in English literature. And so I'm like, I can write about anything. Sure, I'll write a paper for you. And then I looked in the literature and there wasn't one article, not one. And so I was like, I guess I need to do my own research. So I interviewed clinicians about their experiences in radiation oncology and radiology with transgender patients. And one of the things that, these are some of the insights, the points that follow are some of the insights that came out of that work. And the first is that radiologists don't have a solid way to collect SOGI data in clinical care context because of the binary structure that we've created, male, female boxes. And then also the EHR integration, every field needs to flow up to the next. So if you have different answer options or a different structure for your gender or your sex question, and it doesn't translate to the next EHR, then it gets stuck in that kind of lost, unstructured data. Also, sexual and gender minorities, so SGM stands for sexual and gender minority, face challenges at each stage of the system, from scheduling, registration, environment, consultation, billing, supportive care. I already mentioned the kind of binary boxes. And this interviewee, this one radiation oncologist said, I don't even know the right term to use. Like we were having this conversation and he was like stumbling and kind of like, I don't even know if I'm using the right words right now. So this is a big issue, particularly for cervical cancer and breast cancer. So for trans men that may need mammography or need to have cervical cancer screening, when we gender things so much, when there are women's centers, when everything is pink, when everything is kind of like very feminized, it's a huge deterrent to people who, and frankly, I mean, I'm not particularly feminine, but I'm female and I'm like cisgender, but like, I don't really want all that stuff either. You know what I mean? Like, so it's like, there's a wide variety of people in the universe. And by kind of super gendering things, it makes it very uncomfortable and deters people from wanting to get care. I was dating someone a few years ago, and she was an ex-football player, and she had never been to a gynecologist, and then was diagnosed with a grapefruit-sized ovarian tumor, which she had removed, but literally no one on her football team had ever gone because these are cisgender butch lesbians from like, you know, that are in their 50s, right? And they don't feel like this is for them, right? So there's a lot of people out there that are not getting screened because they don't feel welcome in the systems that we've created. We also need clinicians that are both culturally and clinically competent. So I've done some work. I was the lead author for a paper with 20 amazing colleagues on cultural training for LGBTQ health kind of competency. And we just kind of listed a number of principles and illustrated a number of principles around cultural humility training and kind of lifelong learning and being open and reflective and inclusive and trying to promote diverse points of view, particularly with multiple trainers. So one person in my study in last January said, this was a very out gay radiation oncologist. And he was like, everyone kind of sees me as the person that's supposed to know about how to treat trans people, but I haven't been trained. Like, just because I'm gay doesn't mean that I'm the trans doctor, like, and I know what I'm doing. And so we need better training, both clinically and culturally. In terms of clinical training, I was really, there's a lot, when you have these aha moments and you're like, oh, I had no idea what I didn't know. Like the idea of if you've had bottom surgery and then you need radiation for cancer, you may not be able to do that. Or if you've had radiation, you may not ever be able to have bottom surgery if your tissue is not amenable to that, right? If it's too friable. And so some of these things like using hyperbaric oxygen, training people to think about long-term health and whole person health of an individual is really important. And we're not doing that in med school right now, So these were things that were really striking to me that came out, particularly since, again, there wasn't one article about gender, transgender care and radiation other than for surveillance, post-surgical surveillance, as opposed to, but nothing to do with cancer. So this is a really big gap. In terms of billing, so sometimes there are insurance rejections. I have a wonderful friend who just got an award here for their work in trans research here in New York, who is an advocate for their patients, but they have had to call insurance providers and said, so you are blatantly discriminating. You have a discrimination policy that you're enforcing in your health insurance because certain things might be gendered in terms of procedure and a company won't pay for them. So CMS has a code that you can use to identify gender ambiguity to avoid having something pushed back because a gender marker isn't matching a procedure. But private insurance companies can do whatever they want. So unless you have an advocate like my friend as your physician, it can be challenging, and sometimes you can have out-of-pocket costs that you shouldn't incur because of these mismatches. Let's see, what else? So what can you do about it? I like to always leave people with resources and kind of not just share the sad stuff. So for providers, if you're a provider, I don't know if there's any providers in the room, this is for you. If you're a survivor, this is for you to encourage your healthcare system to think about, but kind of just thinking about what are your immediate reactions and how is that going to affect the patient interaction and the patient outcome. So I always remind doctors, like, this isn't bidirectional. It's the patient isn't there for you. You're there for the patient, right? So like, think about what your reactions are. And if you have some kind of immediate associations that come when you realize that someone's gay, or you realize that they're queer or they're trans or what have you, take a second, pause, settle in, and then don't make assumptions, provide space to allow for corrections, and focus on what's best clinically for the patient, right? So again, don't ask questions kind of just out of curiosity. Oh, well, can you tell me about this? Ask questions that are clinically relevant because they're there for their care. They're not there for you. Keep the patient at the center. So reflecting the names, body parts, kind of behaviors that the patient is reflecting to you, pronouns, be patient, allowing for space for a response, displaying open body language. I mean, these are things that are helpful for all patients, right? Follow the patient lead in terms of eye contact, being respectful, professional, and non-judgmental. Helping patients feel seen. I mentioned this at the beginning, but intake forms that are inclusive, so non-binary, that include sexual orientation and gender identity options that are not binary, visual displays of inclusive, all the patients that you want to see, creating safe environments, making sure that you're trained and have ongoing training, and making sure that providers are supportive of our sources of social support. And then I also encourage people to screen for minority stress and for trauma, but also screen for resiliency, right? So like, how comfortable do you feel navigating the world with what you've told me about in terms of your identities? And also, how do you cope with stress, and where do you find your joy, and how do you find your support, so that we can lift each other up and tap into that positive resiliency to help support people. And so this is the big one, providing trauma-informed care. And I really appreciated the comment of someone earlier who mentioned, they were asked about whether they had ever been sexually assaulted. And, for trans individuals, just having a speculum, as part of an exam can feel extremely traumatic, right? And so like paying attention to all of our trauma, we all have a lot going on, and especially with all of the social polarization that is out there right now, there's a lot that we're carrying, right? So coming into an encounter and just thinking about what's happened to the person in front of you and not assume that they're just kind of this mythical unicorn where there's nothing wrong, right? And so what can you do for trauma-informed care? You can give as much power to the patient as possible. Articulate what's going to happen before you do it. Give options. Provide, for example, for cervical cancer screening, there are alternate positions, side positions. You can have a patient insert their own speculum. There's lots of things that you can do. Anti-anxiety medication to help make sure that you're not reinforcing traumatic experiences and helping to provide the safest and most affirming environment possible. Show you have a safe environment. These are some resources that my team has put together. This is, the image is not great quality, sorry about that, but the I Want You to Know card is really asking about name, pronouns, sources of social support, potential areas that might get in the way of treatment, and letting people indicate what's important to them in terms of their values and priorities for care. Our welcome poster is in 7 languages and has our rainbow heart. And then there's some tips for providers in terms of practicing inclusivity and phrasing that people might practice in trying to provide an inclusive atmosphere. And all of these resources are free. In addition, I'll just give another plug. Nancy mentioned our navigation training that NPI adapted with permission, and we were very excited about, so that she could translate that into Spanish and reach people globally. That training is also available for free at bit.ly/PN training. So all of the resources that come up from like a result of the research that I do are always free, and they're available on our website. So these are QR codes where you can access these materials if you want to share them with anyone else. And then I always kind of like to also just kind of end with a call to action. So even if you're, I think it's so beautiful, and I'm so like humbled and honored to be in the room with all of you, because there's just such a feeling of collaboration and kind of mutual support that is so important right now. And so even if you're not a provider, and even if you're not an administrator, as a survivor, as a peer, as someone who knows people who have services, like, how can you be a champion? What can you do where you live, work, where you go to care? If you notice something that is not inclusive, where can you show up and be part of the solution? So this is my information. You can get our newsletters if you want free resources or you want to know about them. Follow me on LinkedIn if you'd like. You can access our resources and trainings, and I'm happy to take questions. I hope some of that was helpful. So. So hopefully people will join me.
Oh, any questions from the audience?
Hi, my name is Linda Hayes. Thank you for the information, but I got a comment/question. I work for the Alabama Department of Public Health for the Breast and Cervical Cancer Early Detection Program, and I have a friend that's the same sex. And what was curious when she was asking me my job, because I was telling her I was traveling and everything, and I asked her about, getting her mammogram and her pap test. Her comment was that her wife does, but she don't. And I did not understand that because I was like, well, you still have the same parts. So, I didn't want to cross the boundaries, but then I was trying to understand, because what I was trying to explain that, okay, that's true. And she kept on saying I'm gay. Okay, I don't have a problem with you being gay. My problem is you still have the same female organ. And if you get breast cancer or cervical cancer, if you die, you're a number. So could you like elaborate on it, or? have any comments. I just didn't understand.
Yeah,
what
I
you said.
mean, I think we haven't done a good job of being inclusive in our healthcare system on a lot of fronts. And so people who don't identify as, particularly feminine, even if they're in a same-sex relationship, that I've experienced that quite frequently. Like I said, in terms of people in my personal life, that just don't feel like, oh, well, that's not for me, because we haven't marketed it that way, right? Like we've marketed come to bars, smoke to be cool. The tobacco and alcohol industries have been super welcoming of queer people, right? And so that's like where our safe spaces are, and that's where our heightened risk is, because that's where we could be ourselves, right? The healthcare system, if they were like half as affirming as the tobacco industry, wouldn't that be amazing, right? Then maybe we wouldn't have these stories. But yes, if you have a body part, I was just talking to someone who's actually leading some work in the colorectal screening space in the queer community, and he was asking me how I talk about these things. And I'm like, if you have the body part and it's screenable for cancer, get it screened. If it's a screenable cancer and you have the body part, get it screened. I mean, that's pretty much what it comes down to. But that doesn't mean that we have good guidelines, because we haven't stratified our research data. So for cervical screening, for example, if you don't have a pathologist that knows what the difference between a PAP with someone who's on testosterone looks like, you could have a false positive, and it might look like you have a problem that you don't have. And so there needs to be training, there needs to be data collection, there needs to be increased research so that we can provide excellent care to everyone across the continuum of our non-binary identities, right? So thank you for the comment. I wish I had a better answer other than, yes, I see that all the time.
I'd like to invite moderator Karen North, a cervical cancer survivor, 2019 Survivor School graduate, and the survivor LGBTQIA lead, along with Dr. Shannon Kozlovich, a community engaged research scientist with a focus on critical areas, and Gilma Pereda, a cervical cancer survivor. Please join me in welcoming them.
Thanks
Thank
for
you very
joining me.
much.
I was lonely up here.
I'm going to ask a few questions of the panel, but before that, I'm going to introduce myself. Like Christy said, I am a 7-year cervical cancer survivor. I'm also a 9-year breast cancer survivor and an RN. I was married for 10 years prior to being involved in now a 20-year lesbian relationship. Sexual gender minority is very near and dear to my heart. I have a dear friend from college that transgendered, and I ask him questions all the time. So I'm going to start off with a question for you, Mandi. Would you discuss what medical mistrust would be?
Oh, yes, medical mistrust. So, gosh, and we didn't prep for these questions either, so I'll try not to be long-winded. I think this goes back to the comment I was making earlier about our healthcare systems not being set up for all people, right? I mean, they were really set up for white men, really, and then white women, and then an assumption of straight cisgender kind of identity. I remember walking into the hospital that's affiliated with the institution where I work with someone that I was with several years ago, and they were getting bottom surgery, and every single person other than one nurse misgendered them. So like when you walk into a system, another friend of mine was at an appointment and they dead named her in the waiting room, and she just left because she was just like so embarrassed that she is sitting there and they just used a male name to introduce her, and everyone is like looking around, right? So she just left, even though she needed urgent care. So I think our mistrust is earned. We've created mistrust, and we need to intentionally undo that, just as we need to intentionally undo the racist structures that are in our healthcare system as well.
Thank you. And just to explain what dead name means, When you have somebody that is transgendered and you call them by their birth name, you are calling them by their dead name. Thank you for joining us virtually, Shannon.
Yeah, great to be here.
How does one find an inclusive provider?
Those are always fantastic questions. A lot of it will depend on the area that you're in. I know that there's different levels of ways that providers describe whether or not they're inclusive. But a lot of times it's word of mouth. I mean, we rely on our networks to ask other queer women or ask other trans folks whether or not they know of anyone that they've gone to see that does an excellent job. And sometimes you can have a great provider, but that doesn't continue throughout the entire care continuum. I mean, I have a good friend who walked in to check in for a hysterectomy appointment. And the person that he was checking in with behind the counter said, "I'm sorry, we don't do hysterectomies for men, sir. What are you actually here for?" And he had to lean over the counter and say, "Can you please take a closer look at my file? That is what I'm here for." That's not going to have him come back. Even though it was a very, very inclusive provider, that doesn't mean that the hospital staff was also trained to be able to do that.
Absolutely. Thank you, Shannon. Gilma, I'm going to ask you, what types of gender identity have you seen personally on registration forms?
The typical male, female. That's it.
What would you request providers to use? Would you prefer them to have he, she, her, they, them, all of them listed so that someone can check them off?
Yes, definitely, because well, it's like the example you presented, like male, female, transgender. Transgender is starting from there.
Right.
We're not understanding what transgender is. So we have, I think it'll be great if we could include non-binary people also, and I don't know, male, female, because it is just gender.
Can I say something on that? So the question that we're testing right now, that we're including in our research right now, is asking people to select all that apply, that include man, woman, cisgender, transgender, non-binary, and then also having an option for not wanting to disclose. We also have a follow-up question asking, if you chose not to disclose, can you tell us more about that? You know, so trying again to get out of this, we're so fixed on our boxes, and as a researcher, boxes are way easier than messy data, let me tell you. But like, it's not the world we live in, and it does an injustice and a disservice to how we actually are as people and how we live our lives. So I know it's hard to do. I always I'm like, okay, we're trying to cure cancer, but we can't like cure this, we can't figure this out. So like, I mean, yes, it's hard, but I think that's on the research community to figure out, and not on the individual to try to fit into the clinical or the research assumed kind of box.
Thank
Yeah.
you.
I also think there's a lot to be said for how the English language functions. And as another scientist who came into science from a love of English and words, like our language has separate terms for sex-based terms that are male and female, and separate terms for gender-based terms that are man and woman, or boy and girl, depending on your age in our society, or gender expression terms that are masculine or feminine. And so the fact that our language already has that built in, but we haven't yet been able to build it into a lot of our data collection, fascinates me as both a lover of language and also as a scientist. I'm just like, our language conventions already exist here.
Absolutely. Shannon, we've got time for one more question. What suggestions do you have for cervical cancer patients to specifically discuss with the provider regarding gynecology access and treatment?
Yeah, I think that's a really important question. I mean, what it comes down to is that not everyone who has a cervix is comfortable in a women's health setting or a women's health clinic. And not everyone that has a cervix or a uterus looks like a woman or what our society expects women to look like. So I think just a lot of the community-based education needs to be around, if you have the parts, get them screened. Exactly what was said before by our presenter. And we need to do a better job of talking to the other folks in our communities about that and making sure that they are getting screened for the parts that they have. And we also need to ensure that providers are educated so that they don't scare trans men or transmasculine folks out of the clinics when they do show up.
Absolutely. Thank you so much. I'm going to kind of put Dr. Eckert here on the spot, but one of the things that she wrote in her book that resonates with me is a cervix is a cervix. And we need to really think about that. It doesn't matter what they look like. It does matter what's under the belt when it pertains to them getting health care.
Thank you so much. Please, round of applause for our panel. Thank you. Again, I do want to encourage you to use the parking lot, use your Post-its if there are additional questions that you have.